My old face when I was looking at Cleveland had like just like
Good morning, everyone. Welcome to the Pediatric Grand Rounds. Thank you for joining us today. If you are anywhere near the Mill Mountain Conference Room at the Tanglewood Complex, please come in and join us in person. And as always, we welcome those joining us online. Today's speaker is Dr. Joseph Tamez from the Department of Pediatric Pulmonology here at Carilion. He's originally from Dallas. He received his BA from Benedictine College, his MD degree from University of Texas Medical School in Houston, and completed his pediatric residency at Arkansas Children's Hospital. He came to Carilion in 2001 after he completed his pediatric pulmonary fellowship at Cincinnati Children's Hospital. He has been very actively involved at all levels in the educational endeavors of our department, student level and resident level, and was the recipient of the Humanism in Medicine Award in 2020. Please join me in welcoming Dr. Joe Tamez.
Good morning, y'all. I appreciate y'all being here, including some who had the overnight call. And for those of you online, if you have any questions, if you can send in via chat. My discussion today, some of the points that I'm making can be a bit telegraphic, so please send any questions at any time so I can help clarify that, because asthma as a clinical topic is quite a big topic, and there has been a lot of excitement of some of the newer therapies that are becoming available, but it emphasizes to me how, particularly for asthma, the common everyday workings that we do in caring for patients with asthma remain primary and the majority of the thrust of our care, and where we can receive the most benefit improving the health of our children who have asthma. So the title of my topic is Nuts and Bolts, Puffs and Pokes. And I hope that with this topic we'll be able to review that and also emphasize how day-to-day care and emphasizing patient and family involvement can enhance the outcomes and betterment of their health, even aside from a lot of the newer and technological advances that we have in asthma upcoming. So for this talk, I have no conflicts of interest, but I will include names of the common trade names of medications that we commonly use here in the United States, because that's helpful to clarify what's available here in the United States in contrasting care and access to medications in other countries. My objectives for this talk are to review and to compare asthma therapy guidelines, and I'm going to contrast the most recent updates of two guideline entities which we clinicians who care for asthma follow commonly here in the United States. I'll discuss the rationale and limitations of devices used to optimize inhaled therapy, and I see one of my former colleagues here who has gone through a lot of these developments over time to get us to where we are today. I'm going to enumerate factors that affect asthma control. I try to emphasize factors that we as clinicians can do, even in looking at what I call low technology or more easily accessible care for asthma that does not involve high cost or high technology driven therapy. But no talk today, especially in this day and age, for children who have asthma will be complete without reviewing some of the new biologic therapies that we have available for children who have difficult to control or severe asthma. Asthma, as we know, is a heterogeneous disease with the main physical pathologic manifestations of bronchial smooth muscle spasm and airway mucosal inflammation. These are a lot of the understanding we have for the pathology of asthma has really exploded over the last 10 years in regards of the mechanisms of disease and given us potential insight into the ontogeny of asthma. This involves a lot of effectors within the airways. Different cellular pathways and inflammatory pathways are known and are being used currently to direct more focused asthma care, particularly for difficult to control asthma. The main manifestations are cough and wheeze and airflow obstruction, and what we hope we can do is to improve and reduce exacerbations of asthma that can be severe or even sometimes fatal, and reduce the risk of loss of function and impairment over the lifetime of a person who has asthma. Because we know that asthma is a chronic disease, it's variable from person to person in its remittance and reemergence, And currently, there's no curative intervention for asthma. So I'm going to review here the current prevalence of asthma. This is a recent review I've done of the CDC website to look at the prevalence of asthma in the United States. And the most recent review shows a trend of asthma prevalence in the United States for all persons from 2001 to 2021, which is pertinent because that happens to be my career in asthma care. What we can see here is that overall the prevalence of asthma in the United States has remained about the same at about 7.5%. Of course, with increased population, that means that an increased total number of persons with asthma. In the United States, the average for adults is about 8%, and for children, it's about 6.5% prevalence over the prior year. In Virginia, we don't have any numbers for children. The adult prevalence is about 9 to 10%. And in Virginia, if you break that down by regions, in the regions of Virginia that are the eastern region and the southwest region have a higher prevalence than the more northern regions of Virginia. If you look at that differently, you see here a breakdown by age groups, the current prevalence of asthma in 2021. And you see here for the children in the young age group, 0 to 4 years of age, the prevalence of asthma is quite low. And that probably reflects not only the evolution of asthma in time as we get older, but also the difficulty in diagnosing and recognizing asthma as an entity separate from wheezing related to illness. In the age groups for children and teenagers, you see that there's an increase and there's a higher prevalence in males compared to females. That prevalence of males more than females changes in the mid-20s to the 30s where it becomes more prevalent in females. And the prevalence in females tends to be relatively stable over the higher age groups, whereas for males it tends to decrease over the higher age groups. Asthma causes episodic worsening, and this is a review of the prevalence of asthma attacks in the prior 12 months for any person who has current diagnosis of asthma. It's broken down here by age for children 17 years of age and younger, and adults 18 and over, and the trend between 2001 and 2021. What we see here is that there has been a significant decrease in the prevalence of asthma attacks, having at least one asthma attack in the last 12 months. But it's still fairly high. In children, we see that has decreased from about 60% to a rate of about 38%. And in adults, although at the beginning of this time frame, you see that it's lower prevalence of asthma attacks in adults than children, it does decrease to be about equivalent to that in children. What we need to recognize here is that in this data, we see that as much as 40% of persons who identify as having asthma currently have had at least one asthma attack that is considered significant, severe, requiring some type of intervention. So recognizing that is important to consider when we are trying to improve their outcomes. Here we know that fortunately, although asthma-related mortality is low in general, it does happen, and we have seen fortunately a decrease of that in general. This is a graph that shows the trend of asthma-related deaths by percent. For all populations, this is about 8 to 9%. In children, the asthma death rate is about 2 per 1 million, so that's low, but it does happen. And for certain groups, such as non-Hispanic blacks, the death mortality rate for asthma is about 7 times higher than their Caucasian counterparts. And boys are more likely to die from asthma than girls. And for children, it is the leading cause of emergency department visits for asthma episodes. And it is one of the most common diagnoses of non-surgical hospital admissions. So there's quite a burden upon our population in general in regards of asthma, and we want to improve that. So decades ago, the two professional entities were formed to help address this. And the one that we have used most commonly in the United States is the NAEPP, the National Asthma Education Prevention Program, which was formed by the NHLBI and in 1989. And that entity is a group of stakeholders who review asthma care, asthma literature and science, and publish recommendation guidelines for asthma care. And this is the basis for a lot of the clinical care that we use here in the United States for children. And they have publications that have been put out since 1991. 4 total complete updates have been done. The most recent one actually was in 2007. But the NAEPP has from time to time given updates, and the most recent focused update was in 2020. This 2020 update will be the focus of the next few slides in my discussion regarding the guidelines and changes those guidelines that we have currently that really have begun to show a shift in some of our thinking and how we provide day-to-day care and therapy for children with asthma. Another professional entity is the Global Initiative for Asthma, and that was formed and trained in conjunction with the World Health Organization and the NHLBI to promote a strategy for care for asthma throughout the world, taking into account the science and resources that different countries around the world may have to help address this problem. The Global Initiative for Asthma, or GINA, puts updates every year, typically in May, around World Asthma Day, which most recently has given an update. But they began publishing in 2002, and the most recent update I'll review as well, and compare the 2 most recent updates for these 2 entities here, and put it in light of how we care for asthma day to day here in the United States. What's most important to recognize in these next few slides is that there appears to be a shift away from using short-acting beta agonists, or here in the United States, albuterol. Albuterol has become the basis of our acute response to rapid onset of asthma symptoms and relieving distress and preventing respiratory failure. So to me, in my mind, this is quite a shift in thinking in considering use of this, availability of this on a day-to-day basis for persons who have acute asthma symptoms. In 2014, GINA introduced SMART strategy, or actually I should call it MART strategy, for persons who are 12 years of age and older in the STEP guidelines that they published for Step 3 and Step 4 level care, and I'll go over these here in a moment. In 2019, they actually recommended against short-acting beta agonist use in children or older children and adults in Step 1, and have begun to promote combination long-acting beta agonist therapy in combination with inhaled corticosteroid, in preference to the alternative of inhaled corticosteroid and as-needed use of short-acting beta agonists or asthma, which really has been the backbone of asthma care and outpatient care for asthma here in the United States. The NAEPP most recent update was in 2020. They made a conditional recommendation for use of as-needed inhaled corticosteroid plus albuterol for Step 2 for persons who are 12 years of age and older. That's a significant difference because in my training and my education, we always learned that if you have therapy that requires Step 2 therapy, which is typically mild persistent asthma, inhaled steroids on a daily basis is the backbone of good therapy. And in this update, they also began to promote the consideration for SMART therapy, single maintenance and reliever therapy, long-acting bronchodilator, particularly in the United States, formoterol, with inhaled corticosteroid combined in one inhaler and using that on a daily basis for maintenance for those who require it, but also for acute relief of symptoms in place of short-acting beta agonists. This is notably for Step 3 and 4. They promote that for 4 years and up. And I'll highlight that in regards of what some of our limitations in considering that for care here in the United States. I put this table in here just to review briefly the asthma severity categorization that we have promoted by the NAEPP. It breaks down asthma severity as we assess this at the time of diagnosis of asthma as intermittent asthma, mild persistent asthma, moderate persistent asthma, and severe persistent asthma. And these are formed when we get history and observations for persons with a suspicion of asthma by the symptom frequency, not only through the daytime, but also nighttime. And there's some difference in severity categorization by frequency of symptoms by age. Particularly the younger children have, if they have more frequent symptoms, that carries more weight in considering their asthma severity classification. And so at an age-appropriate time, we can introduce in pulmonary function tests or spirometry to also add to that. So most of our severity categorization is based on observation and history that we receive from patients. So relatively low tech. And these have been helpful for us to begin therapy for a person based on their initial classification of asthma severity. So now I will change to show you some of the age groupings guidelines for the NAEPP. This first one is the stepwise guidelines for care. The steps here are in relation to what options we have for therapy for asthma. And each step, increasing step, denotes an increased need for therapy to improve control of asthma and to minimize exacerbations. They go from step 1 to step 6, with step 5 and 6 mostly related to severe asthma or poorly controlled asthma. I've highlighted here in the step 1 for this age group, 0 to 4 years of age group, the changes in the 2020 update that NAEPP published. What is notable here, they note at the start of a respiratory tract infection, which we understand is a very common cause of wheezing and distress and hospitalization in children, at the start of the respiratory illness, we will add a short course of daily inhaled steroid along with short-acting beta agonist. So this is a practice that a lot of us clinicians have used through the years, even before this recommendation was formalized in this publication, but one that, as it's formalized here, will become a better option. The reason for that is that it has been shown that introduction of inhaled corticosteroid with regular use of short-acting beta agonists can reduce the progression of an asthma episode to a severe event. What's also notable, and I think even more notable in this categorization recommendation, is that for children who are age 4 years and up, for step 3 and step 4 care, we can consider using step care that is equivalent to what we see in the next age category, which I'll show you, for 5 to 11 years of age. So this is a significant change. What we see here in step 2, mild persistent asthma is typically recommendation to begin low-dose inhaled steroid and use of albuterol as needed. These other alternatives are down here at the bottom. I will just mention, but not cover today specifically. This next group has to do with the 5 to 11 years of age group. And I've highlighted here the significant changes in the 2020 updates, particularly for step 3 and step 4. In that prior slide, we mentioned that for children 4 years of age and up, we can consider, if they require step 3 and step 4 therapy, we can consider the use of daily and as you needed use of low-dose combination of ICS formoterol. And that's specifically inhaled corticosteroid plus formoterol as a long-acting beta agonist. It does not make recommendations for other long-acting beta agonists specifically for this mode of therapy. And the step 4, increasing that to medium dose. In past, we would have as the main structure is to use low-dose inhaled steroid for step 2. Step 3, we would double the dose of inhaled steroid if we need to gain better control, and then increase or add other therapies as we need to gain better control. Also, in this categorization, they begin to recommend a conditional recommendation to consider use of subcutaneous allergy immunotherapy if there is good control, the conditions that allergists need to be aware of if they have a person with asthma, they would like to begin asthma allergy therapy. So this is added in there. It's a therapy that we have considered commonly for youngsters through the years, but it's formalized here. And also they've added here the consideration for more severe or difficulty to control asthma to consider biologic therapy of omalizumab or trade name Xolair to add on to higher dosing inhaled therapy. Now the third categorization of age group is 12 and up, includes teens and adults. Several different changes are notable here, and this represents some of the challenges we'll see in trying to compare these to the GINA guidelines. In step 2 care, most typically for mild persistent asthma, there's a recommendation, not the first recommendation, but second recommendation is a preferred course of use of as needed inhaled corticosteroid and short-acting beta agonist, not a long-acting beta agonist. So that's important to recognize between step 2 and step 3 here. So use of an inhaled steroid and albuterol as needed for folks who have a categorization most commonly as mild persistent asthma. That's a big shift in thinking for us clinicians. This is in addition to the prior considerations for low-dose inhaled steroid and as needed albuterol. In step 3 and step 4, there's an introduction of use of daily and combination low-dose inhaled steroid plus formoterol, and increasing that dose for step 4 and step 5. So this again is a big shift in recommendations that we've had prior to this. It also, as I'll show you, highlights some of the challenges we have as clinicians in providing that therapy for our patients, and including for higher step care, introducing other biologic therapy as possible adjuncts to inhaled therapy. Some of the newer ones that were FDA approved for use for this age group in the United States at the time of this publication. So I'm going to shift now and show you the most recent publication for GINA and show you some of the differences in that for these different age groups similarly. So in the GINA guidelines, this is the 2024 publication, it shows that here in this line here, you see that as needed short-acting beta agonist is used for acute symptoms. In what we consider step 1, roughly equivalent to step 1 by the NAEP guidelines, it recommends intermittent short-course inhaled steroid at the onset of viral illness. It says you can consider short-acting beta agonist and use that for the increasing step care as its acute reliever. Daily low-dose inhaled steroid is for step 2, and considering doubling the dose and stepping that up or seeking additional care for higher step care plans. So this is very similar to what we have commonly used for children in this age group here in the United States. But if you look at the older age groups, you see here for step 1, intermittent asthma, they recommend low-dose inhaled steroid taken with a short-acting beta agonist. And for steps 3 and step 4, consideration of maintenance and reliever therapy, similar to what we saw in step 3 and step 4 for the NAEPP guidelines, use of a low-dose inhaled steroid, long-acting beta agonist, and using that for acute relief of symptoms when they're having acute symptoms in place of the short-acting beta agonist. So here for step 2, what would be equivalent to mild persistent, they continue to recommend daily low-dose inhaled steroid. For the older age groups, they have promoted 2 tracks. One is the preferred track. The second one is the alternative track. And what we see here in the preferred track, their higher recommendation for step 1 and step 2, those who would most commonly be classified as intermittent or mild persistent asthma, use of as needed only dosing of combination inhaled corticosteroid and formoterol. And in the United States, we have promoted this as smart therapy for those who require low-dose inhaled steroid regularly in the form of ICS and formoterol, plus using those as needed. So in this recommendation, the preferred track does not include short-acting beta agonists. So that makes me think, what's going to happen to albuterol use in the future? So as with increasing severities, you'll see that there's increasing add-on therapy and consideration of biologic therapy for more severe classifications. So in the alternate track, more similar to what we have continued to use here in the United States, they recommend, similar to the NAEPP, taking an inhaled corticosteroid plus a short-acting beta agonist when there's need. Most recently here, there has been FDA approval for a combined inhaler that includes an inhaled corticosteroid with albuterol equivalent here in the United States, which has been available in other countries for some time. So using this combined inhaled steroid plus a short-acting beta agonist for step 1 is considered an alternative to long-acting beta agonists with an inhaled steroid as needed. And step 2 and step 3 is very, very similar to our current guidelines of low-dose maintenance inhaled steroid and low-dose maintenance inhaled steroid plus long-acting beta agonist. Not necessarily formoterol, but other long-acting beta agonists can be considered. And the reliever can continue to be the inhaled steroid plus short-acting beta agonist. So that's considered an alternative track. So for us clinicians in the United States, which have used the NAEPP guidelines, but also look to the GINA guidelines because those are very helpful in a more rapid up-to-date of information and therapeutic recommendations on a yearly basis, it creates a bit of a conflict for us. Not only here, the problem of here in the United States, the only combined single inhaler that has inhaled corticosteroid with formoterol is budesonide and formoterol, or brand name Symbicort here. And the dosing of that in the United States by FDA approval is for the maintenance therapy to be given as 2 puffs 2 times a day. It does not recommend lower number of puffs. It does not recommend use of ICS formoterol as needed, as these updated guidelines promote. So that creates a conundrum, but also creates a conflict when we want to consider this therapy for our children, but we meet certain barriers to achieving that. Not only what dosing do we use, because the FDA approval is 2 puffs twice a day. The GINA guidelines say for low-dose ICS formoterol, we can use even 1 puff twice a day. So this group, this publication by this group, which includes persons who are on the committees of both GINA and NAEPP, recommended this consideration for budesonide formoterol dosing for smart dosing here in the United States. So for the age groups 12 and up, the budesonide formoterol is most commonly in the 160 microgram strength of budesonide and 4.5 micrograms for formoterol. The maintenance therapy for step 3, those would probably be equivalent of moderate persistent asthma for 12 and up. They recommend 1 puff daily of the ICS formoterol and can even consider 1 puff twice a day of ICS formoterol for maintenance. And you could add 1 puff of the ICS formoterol as needed for acute symptoms. If you have step 4, need improved control for moderate persistent asthma, you can increase that to 2 puffs twice a day. For children, the recommendation is for the 80 microgram strength of the budesonide and to use that as 1 puff once daily for children for step 3, what would be equivalent of moderate persistent asthma. That's a big mind shift for me as a clinician, because we typically, in this step plan, would increase to medium strength of inhaled corticosteroid. And that you can give this patient 1 puff of the ICS formoterol as needed, similar to the older age groups. And 1 puff twice a day of the 80 is the recommended maintenance for step 4. They also recommend maximum number of puffs of these per day. Max puffs per day is 12 puffs, which sounds like a lot of puffs. But if you're considering that is in place of the short-acting beta agonist, maybe not so much if they're having a severe attack. And for children, the maximum puffs of the 80 strength is recommended to be maxed out at 8 puffs. So that's, you have a question?
So sorry, I didn't mean to interrupt you mid-sentence. I'm just wondering, you know, with the max inhalations, is there a time period in between, or like, are we? I could just see kids at home going, okay, I can get 8 of these, and just puffing all over.
Right, exactly. So it's important to recognize that when we use short-acting beta agonists for acute severe episodes, we recommend multiple puffs of the short-acting beta agonist, albuterol. Well, we have to educate our families that this is different, and they have shown that, and have as a general recommendation, that if you take the ICS formoterol acutely for acute symptoms at that moment, 1 puff, and you have continued symptoms, you need to repeat the puff, you can do that in sequence up to the max dose at whatever time that you require. So not real clear on disclosure of what the time interval that may be. For those of us in the hospital, we have very regimented times, and we have regimented times. We say wait at least 20 minutes for the albuterol to kick in to decide if you need additional doses. So yeah, it's not very clear in my review of this if there's a time frame, but they say repeat as needed up to the max dose. So of course in that time frame, if things are worsening, you would want to have an interaction with the healthcare provider. So, so the challenges are, 1, the FDA approval of the ICS formoterol here in the United States is approved only for 4 puffs a day, not less, not more. And the age of indication for these is a factor as well. Budesonide formoterol is actually FDA approved for 6 years and up. Well, the updated guidelines in NAEPP say consider this therapy for children who are 4 and up. So that inherently creates a conflict with our recommendations and also potential availability of coverage for this inhaler. And looks like we're frozen. Okay. Currently, it's the only one that's recommended in both the GINA guidelines and the NAEPP for that age group. So there are advantages to SMART. It has been shown in clinical studies that it decreases the risk of severe exacerbations, it decreases the risk of progression, it decreases the overall prevalence and frequency of those. It also can decrease the overall inhaled corticosteroid cumulative dosing, which is a primary focus for all of us, and it has been emphasized in the GINA guidelines. It can improve symptom control. So patients not only have better symptom control day to day, they have less risk for exacerbations, and their overall total inhaled corticosteroid dose is less. So it has been shown to that. But there are disadvantages. One, the dosing recommendations, which I just discussed. The cost of this in the United States, the cost of these out of pocket is high compared to other countries. And then there is the possible overuse. We have folks who we discuss who are poor perceivers of their asthma symptoms. We have patients who are high perceivers of asthma, and the high perceivers, we may have evaluation, they look well, but gosh, they're sure taking a lot of albuterol. What happens when they take a lot of their combination control inhaler? And so all the other side effects that we can have with albuterol, we can see with the long-acting beta agonist: increased hypertension, increased heart rate. And there's always, in the background of this, we're remembering that here in the United States, we have the black box warning on long-acting beta agonists to watch for potential for more severe events in asthma. That has actually not been so far shown in SMART therapy in other countries. So we hope that will bear out in time. Okay, so here's just a table of, here in the United States, forms of inhaled steroids and long-acting beta agonists that are available. We talked about the budesonide formoterol meter dose inhaler, which is brand name Symbicort, but its generic Breyna is now available. The age of indication is for 6 years and up for the 80 microgram, and 12 and up. So that creates an inherent conflict sometimes with coverage. Other combination control inhalers are dry powder inhaler forms, which may not be optimal for younger ages, even though the first combination controller inhaler with a long-acting beta agonist, Advair, came out in the discus form back in the early 2000s and was FDA approved for 4 years and up. I have very low success in having 4-year-olds use a dry powder inhaler, particularly the Advair discus. But it comes in an MDI inhaler, but the FDA approval for the MDI inhaler of Advair is 12 and up. Mometasone plus formoterol, brand name Dulera here in the United States, has different strengths. It has formoterol in it, which is the long-acting beta agonist of choice in the current guidelines for GINA. Is FDA approved for 5 years and up in the low strength, but it has not been promoted by these guidelines as an alternative to budesonide formoterol. In other countries, beclomethasone, brand name Qvar in the United States, is available in a ICS formoterol formulation single inhaler, but not here in the United States. Yes.
Is Dulera a dry powder?
I'm sorry?
Is Dulera a powder?
No, Dulera is a meter dose, pressurized meter dose inhaler here in the United States, yeah. Mometasone alone is available in a dry powder inhaler, but not with the long-acting beta agonist combined. So there is an emphasis on consideration of using single inhaler rather than 2 separate inhalers, which is part of those recommendations because of ease of use and increased chance of improved adherence. Okay, so this slide, this graph, is one that was constructed by Dr. Bussey and Kraft, who are well-read in asthma literature, to look at reasons why, think about why we as clinicians may encounter patients who have uncontrolled asthma and what we can do about it. This top line shows some of the common reasons that we may see for uncontrolled asthma, and they're very common. Those of you who take care of asthma deal with this every day. We talked about poor inhalation technique, poor adherence to medication therapy, which can be combined with poor inhalation technique or understanding of the use of those. Looking at triggers, recognizing triggers, and avoiding those triggers is a common topic of discussion for us. And looking for comorbidities. That's one of the main jobs for us as specialists, to understand if a child is uncontrolled with their asthma, how we can improve that. But we need to think about suboptimal care. And I consider among components of suboptimal care is access to care, having access to clinicians who feel comfortable with younger children or are aware with current guidelines, best practices, but also place of care, distance to care, which is a big consideration here in this part of Virginia, and also how that affects family life and being able to interact with their family member who has asthma. Another component which I have considered but not really formalized that this review mentioned already as well, is that when we see children, when we're assessing their control, we have to be aware that we commonly see that patients and families will commonly underestimate the severity of their child's asthma and not recognize that they're not well controlled. A lot of times control is considered, well, when I have an asthma attack, I have these tools to use and I can avoid going to the emergency room. Well, that's good, but day-to-day is affected still. On the other hand, for clinicians, we have to recognize that it's not uncommon for us to also overestimate the control that patient is experiencing. So being aware of that, having discussions, getting the best information and history we can from our patients and families is important. We need to include shared decision-making. And those of us who care for children, we see that we need to include children as they age, developmentally begin to involve them in their shared decision-making and include them in self-management. In doing so, we need to increase patient education, carefully select therapy, and have active discussions regularly about what we do for day-to-day care and also how we can react to episodes of asthma. Increasing healthcare technology, remote monitoring has become a big help during the time of COVID and has continued to be helpful for folks who live remotely from their asthma care centers, and increasing communication between not only healthcare providers, but other adjunct educators for asthma. Communication is important, and this is the basic tenet of all chronic care. Simplifying treatment regimens is part of the goal of these promotions of these two guidelines to have better control of asthma with less inhalers. We all have seen patients come to the office and they have 3 or 4 inhalers and they're not quite sure which one they're using on a daily basis. So simplifying the number of inhalers not only will be cost effective, but also improve adherence. Okay. I'm going to go to the next slide. I'm stuck again. So one of the things that we commonly get asked when we see children is, why do we use spacers? A lot of the students ask me that, and they ask me, why do we use spacers? Well, spacers for pressurized meter dose inhalers have been around as long as aerosol therapy has been manufactured for the care of asthma, for decades and decades through the 1900s to today. Nebulized therapy has been made, and for younger children, we've commonly promoted use of nebulized bronchodilator acutely, and also nebulized inhaled steroid for maintenance therapy. When we're asked, well, Dr. Tamez, which would you prefer, an inhaler for this child or a nebulized inhaled steroid for this child? And we have to think about that. This is a study that these 2 investigators did, an in vitro study, looking at deposition of nebulized inhaled budesonide and with several commercially available nebulizers. I always tell parents that the nebulizer is actually the cup, not the machine. The nebulizer is the cup. So different nebulizers were studied here and to look at the impact deposition in an in vitro study. This picture here depicts one example of an in vitro study. It's usually a mechanical construct that tries to replicate inhaled techniques, different inhaled volumes and speeds and such, while nebulizing and to collect that and assess the efficacy or efficiency of the nebulized device. So this is in vitro here at the top. This picture below is what we call in vivo, and this is mostly what we encounter as clinicians. We have a child there with the nebulizer, and he's holding it away from his face with the mouthpiece, and we wonder how much deposition is going on when we use that. So if you look at this graph, the bars represent the deposition, and down here at the bottom represents percent of the total charge, the dose put into the nebulizer and then nebulized. The white component of each bar represents percent that is deposited within 5 minutes of starting the dose. And you see different nebulizers can be quite different in the overall impact deposition of the budesonide. For here as low as less than 5%, looks like 3 or 4%, up to about maybe 12% for this one that shows the highest deposition within 5 minutes. The darker part of the bars represents how much is deposited if you continue on for a longer period of time. I think they went up to 12 minutes. So you can see that the highest percent of deposition for the most efficacious nebulizer component used here is not quite 15% in that 5 minutes. And up to 12 minutes, not much more, not achieving 20%. So when students ask me, well, should we use the nebulizer or should we use an inhaler? We tend to say, if we can, we prefer pressurized meter dose inhalers, because we know in vivo studies in older children and adults, some in younger children, that the impact deposition of the spacers is higher than in these nebulizers. So I commonly will quote to the residents, I'd say, and the families, that it may be as much as 30%. Well, in this study, I realized that I'm probably overestimating the deposition of it. Add to that any behavioral aspects during the time of using the nebulizer, which we all know can be fraught with discord between the child and the caregiver.
Is there a difference in the deposition of budesonide versus albuterol? Is it better for albuterol?
Yes, yeah, there can be. And I didn't quote any studies of albuterol, but the deposition of albuterol is a bit higher. Mainly because some of the albuterol solutions, liquid formulations are more in solution than suspension. Budesonide is more of a suspension. So that can affect the deposition. So yes, a little bit higher for albuterol. I appreciate you bringing up that point, but still quite low for nebulizers in general.
Yeah, is there a difference between deposition and inhalation?
There is. And that's the holy grail of assessing inhaled medication therapy in general for all medications. And the difference between assessing deposition in vitro studies like mechanical constructs and in real life. Some investigators currently are looking at devices within pressurized medium-dose inhaler use with a spacer device that can assess that flow, which we think affects laminar flow in real time and are not intrusive to the live person participating in the study. So yeah, technology advances will help us understand more, but there definitely is. The whole goal of nebulization is to get nebulization and pressurized medium-dose inhalers to get the particle size to a respirable size for the majority of the medication that's dosed out of the device or the inhaler, and create laminar flow to have more laminar flow to get to the lower airways. If we don't achieve that well, we have more impaction on the upper airway, we have upper airway side effects, and we have less deposition airways where we really need those small doses of inhaled medications to do as much work as they can for the patient's benefit. So yes, there is a difference. And when you look at these studies, you have to ask those questions specifically. And that brings up my next point. This is a cartoon representation of a spacer device, and it looks at the different components that we need to think about limitations to device use. We have the pressurized medium-dose inhaler here that goes in, that we place into one end of this spacer device, and we have the patient on the other end. It looks like they're inhaling it through a mask. So the different components of this structure in general has limitations, some effect on overall deposition. And the spacer device has electrostatic forces that can affect adherence of the medication once you actuate it into the spacer that would adhere to the wall of the spacer, and less deposition and flow to the patient. The mask itself, depending on the properties of it, may increase those electrostatic properties and decrease deposition or inhalation into the patient. So we have to think about this when we're using a spacer with a mask for a youngster, or even a spacer without a mask, mouthpiece only, as I call it, and how that may affect the overall deposition. And so each of these components need to be looked at and considered. Interestingly, one of the main components of spacers is the bigger they are, the more deposition or laminar flow will occur. So some of the early manufactured spacers were quite big. I saw a picture of one manufactured by a company in the UK with a child sitting on a person's lap, and the spacer was about this long. And there was another person sitting opposite them holding the device, while the other person is holding the child patient. So can you imagine having to do that each time? It's almost like giving a nebulized therapy. And it decreases portability, which we emphasize having this available whenever we use a pressurized meter-dose inhaler. So the goal has been to make those smaller, less expensive, and more portable. And expense is a factor. My daughter, when she had to purchase a spacer device for albuterol back in the early 2000s, it would cost us $50 out of pocket for it. So that can be a big inhibitor for families acquiring and using that. And they've become less expensive, but as Dr. Millionaire is aware, we've looked at resource-low areas and looked at potential options for using different kinds of devices as spacers. And this is a pictorial showing two different commercially manufactured spacers, actually two spacers that we commonly use here. The Vortex inhaler brand here is shown as an aluminum canister with a valve on the end and electrostatic lining of the canister. The air chamber with mask here is commonly used for infants. It is plastic. It has electrostatic lining that decreases electrostatic forces, but it also has a silicone mask, which is nice and soft to use for a child, but may also increase the electrostatic forces. So in resource-poor areas, they've looked at, well, what can we use? And Dr. Mueller and even one of our residents here looked at this, in particular, how can we construct a spacer on the fly, or if we don't have resources. And it actually has been common to use plastic bottles. In this depiction, commonly available Coca-Cola bottle, which is 500 mLs, to put a hole on one side and have the patient breathe it out the other. And they have shown, in this publication, they've shown that actual deposition, impact deposition, is actually fairly high, sometimes even higher than some of the spacers, particularly with mask use. And they've also showed that the aluminum construct, which has lower electrostatic forces compared to plastic devices, can increase deposition. In this study, you'll see that the construct that they used, they have these two devices here that are manufactured devices. They actually have smaller volumes than these here. And another thing that's important to recognize, that to overcome the electrostatic forces or decrease this for the plastic bottle, they actually recommend either washing it with soapy water or using multiple puffs of the inhaler before puffing the actuation that will be actually inhaled by the patient. So that increases the number of puffs. It can increase the cost as well. So, and so we always promote, even though we recognize that mask can diminish deposition for some patients, they can use tidal volume breathing. And so we recommend this for most children who cannot coordinate a full inspiratory capacity and hold. So we recommend this, we don't recommend this, and we certainly don't recommend this. So I put here a table of the common inhaled steroids that are available in the United States and the different strengths of them. And we do have a lot of choices, but we have to recognize that these inhaled corticosteroids have different properties. The deposition properties of each may be different depending on the actual medication, the formulation, and the actual amount of dose that's presented at the mouth. In the United States, the strengths of the medications are represented as to what it actually presented to the patient rather than what may be actually in the actuator itself. So does anybody have any questions regarding that?
The decreased emphasis on daily routine use of inhaled corticosteroids in that younger age group is the primary reason to decrease the number of inhalers they're using? Has there been any concern about that growth aspect in addition of, I mean, why are we doing that? Because it seems to me like it worked pretty darn well.
Right. Considering some of the main goals of asthma therapy is to reduce symptom severity and frequency, and also reduce the amount of inhaled corticosteroid that's presented, because we know that there are potential long-term and even short-term negative effects of inhaled corticosteroid. And in studies that have looked, they've been large population-based randomized studies, have shown that combination inhaled corticosteroid with long-acting beta agonist, particularly the formoterol formulation, has been shown to have improved symptom control and also reduction in provider-observed interactions, exacerbations requiring provider hospitalization and emergency department visits. So that's a win-win situation. And in doing so, if that can be combined in a single inhaler, that makes the regimen for home use and even potentially the cost less for the patient. So yes, it does appear to achieve those goals, but the difficulty is that for here in the United States, we're not quite there yet as far as availability, cost, and options for therapy. So yeah, exactly as you put.
Can I ask one other thing? Mm-hmm. Back in the day, I seem to remember at least one inhaler, I believe it was an inhaled corticosteroid, that came with its own extender.
Yes, yeah.
Has anybody tried, and I know this may pose some logistical problems, to create inhalers that incorporate an extender as a one-piece item. And I
Yes.
know the size is an issue.
Right, yeah. So we want to improve the portability of it, and decreasing the size and having it attached to the device itself is helpful. So there was, and I'm honestly forgetting the brand name or the inhaled steroid that was promoted with that. It had its own plastic spacer inhaler. It did not have a valve on it. It has been shown that valveless spacers can be helpful in improving deposition compared to actuator at the mouth or even a distance from the mouth. The open mouth technique that has been and is still promoted to some degree with clinicians here in the United States and elsewhere. But the valve actually is important to minimize the risk of cough or exhalation and wasting the dose. And also, particularly for the prior formulations, the CFC propellant formulations that create a cold actuation into the negative degrees Celsius in regard to the temperature of the actual actuation, a startle effect and a cough and a loss of dosing. So the spacers themselves can do it, but the valve is actually an added feature for that to permit that. You think about someone who's using albuterol acutely, they're having trouble, they're huffing and puffing, they may not be able to do a full deep breath inspiratory capacity and hold. So the valve helps reduce the loss of the dose in that regard. So yeah, it does affect some of the impact deposition, but it has been shown that relatively speaking, the relative risk for loss without a valve is higher if you have a cough or uncoordinated breathing. So yeah, thank you for that question. So getting back to uncontrolled asthma versus severe asthma, I think that there's been more emphasis on recognizing this. Persons who have severe asthma, despite good adherence, good education, careful monitoring, they have continued uncontrolled asthma. In looking at severe asthma, uncontrolled asthma can relate to folks who have intermittent asthma, moderate asthma, or severe asthma. And in looking at that, we need to think carefully about inhaler therapies, the choice of device that we have for these, and so those are important. History and testing for allergic triggers is important. We cannot forget that, and educating about avoidance of triggers or minimizing their impact. Looking for comorbidities, most commonly other atopic disease, Th2 response, environmental factors, irritant factors, work-related factors have to be considered. Obesity is an emerging issue. We recognize it as a pro-inflammatory state for all chronic conditions, a lot of chronic conditions, and that includes asthma. Obstructive sleep apnea needs to be thought of because obstructive sleep apnea and asthma can work together to worsen a patient's sleep. And gastroesophageal reflux is actually a common one that we have to think about and exclude and help for patients, even young patients who have uncontrolled asthma. We need to actively and regularly review patients' access to care, but also barriers to optimizing those therapies, be it interaction with an educator, clinician, assessing their severity as objectively as we can, and making sure that they have the best opportunities for access to optimal inhaled therapy. So it's important to emphasize the nuts and bolts of asthma. We talked about inhaled therapy, but education, monitoring, and re-education, supporting them in access to care is really one of the main nuts and bolts of asthma care. It's considered low tech. It is oftentimes hard to achieve. And so our day-to-day work is within the clinic when we are talking to families is one of our most important tools in understanding how we can better help that patient. I will turn now here to my last topic before we finish. There has been a lot of excitement, a lot of emphasis, and if you watch TV, you get a lot of direct-to-consumer advertisement of biologic therapies that are available for uncontrolled or severe asthma. And so these are topics that we talk about commonly with families, and I have families in the past who have asked, can we have biologic therapy? I saw this commercial on TV, would that be good for my child? Well, maybe, possibly, but it's not FDA approved. Most recently, there has been a decrease in age of indication of the common biologics that are available for severe asthma. This is a listing of those. I have here the generic name of the biologic therapy and their brand name here in the United States. Most of these are related to affecting, hopefully decreasing Th2 asthma allergy response. And the majority of them are directed against interleukin-5 And Xolair, being one of the first ones that became available for pediatric patients, has had more recent indications for IgE-mediated food allergy and chronic spontaneous urticaria, as well as chronic rhinosinusitis with polyposis. So unfortunately, we don't see rhinitis with polyposis as often in youngsters, but those indications may help us additional support for considering these therapies. And these are what I call the pokes of asthma therapy. And when you're talking with a family about doing subcutaneous allergy immunotherapy or biologic therapy, that's a big consideration. That's a big commitment for the family. Yes, you have a question? Oh, okay. And here, as we look down here, we have here an anti-IL-4. It's actually anti-IL-4. It also decreases IL-13 interleukins, which are active in asthma and Th2 response. It has most recent new indication for this is eosinophilic esophagitis. So that's a big plus. But it has had a lower age of indication for atopic dermatitis. So I have children who have asthma who've had severe atopic dermatitis who were able to initiate this biologic therapy through their dermatologist, assessing their control of that, and have shown benefit, definitive benefit on their asthma control. So these products not only are directed for asthma, but also other Th2 phenotype manifestations that can be used in severe asthma for youngsters to achieve the ability to use that. We have to recognize that there's a practicality of it, but also the cost. These are extremely expensive, and we don't know the duration of therapy of these. It's also important to recognize that as of yet, we don't have the ability to state that any of these decreases the asthma response as a potential cure for asthma. But that's being looked at, particularly as we're able to use this in children of younger age before the phenotype of asthma evolves. One more biologic is an anti-TSLP antibody as Tezspire. It's one that is different than all the others in that it does not require evidence of a Th2 phenotype or eosinophilic phenotype of asthma to be considered. So for those folks, children and even more so in adults, those who display a non-eosinophilic driven asthma can have this as consideration. So end the discussion here, and I have a few questions for MOC. First question is, factors that can contribute to uncontrolled asthma are, and you can pick one or multiple here. Number one is comorbidities with asthma. 2 is poor inhalation technique. 3 is shared decision making. And 4 is suboptimal medical care. Of those 4, which factors can contribute to uncontrolled asthma? Do I have any?
2.
I hear 1, 2, 4. You are correct. 1, 2, and 4. Shared decision making is one that can be an important intervention to improve asthma control by improving patient-physician interactions. So comorbidities, poor inhalation technique, and suboptimal medical care can contribute to. The next question is the NAEPP guidelines in 2020 update emphasizes formoterol as preferred bronchodilator. Is this true or false? True. I hear true. It is actually false. As of right now, the short-acting beta agonist albuterol is the primary, most commonly recommended short-acting or beta agonist for acute symptoms. So yeah, that trips me up too as well. So it's important that if you are working with a family trying to decide the medication therapy, that we recognize those potential limitations and recognize and educate them that if we were making a recommendation that may not be quite within the FDA approval of a certain medication or the use of that within the contract of those guidelines. So I appreciate y'all being here today. I'll take any questions. Dr. Kermishwal?
Is there a question?
You have a question?
There's a couple online.
Okay.
Dr. Kreider, she just says Flovent MDI is no longer available, right?
Flovent brand name MDI is not available now. It's generic now. It's actually I believe the chemical is still manufactured by the same company. The device looks the same. It's fluticasone propionate. So it's important to have to say that name. I still say Flovent, and parents come to me and say, I have my Flovent, and they gave me a different one. It's not Flovent. I have to tell them that it's actually the generic equivalent. So yes, it is still available.
And then Dr. Baxani said, can you speak a bit about the FDA box warning around singular?
That's a topic I've not touched on today. The warning labeling for singular Montelukast actually came out during the time that COVID was increasing, so in March of 2020. And what it states is that for Montelukast, there have been observations in reported outcomes post-marketing, which had been made before but didn't quite reach the significance that the FDA read as warning. But the second review, they noted that there continues to be reports of adverse events in patients using singular, coincidentally having increase of psychiatric symptoms, primarily of anxiety, depression, and even suicidality. So we have known for years that singular can affect mood and behavior for children and youngsters. Most commonly, it seems to affect their sleep. But these psychiatric symptoms were the reason for making that warning. Having said that, I tell patients and families that we have used it commonly. It can be a useful adjunct, particularly for some children who have more atopic manifestations. So it's still one that I consider, but I have to add that black box warning, and it does cause anxiety for the family members who we recommend prescribing it to.
I'm just wondering, with our asthma care plans that we do all day long for our schools, should we be changing it based on these guidelines? Is it still short-acting beta agonist, or should we be using ICS?
Yeah, here in the United States, until they have an FDA approval for use of formoterol for as-needed use in combination, it's not available as a single inhalation only without ICS in the United States. It had been, but we recognize that use of any beta agonist without consideration of inhaled corticosteroid leads to worse control and severe outcomes. So in the United States, we don't have the ability to officially say that. So when we're talking to schools, government-run schools, we have to acknowledge that we don't have the ability to use that in that context. We're asking school nurses to give a non-FDA approved inhalation at school for their child, so for their students. So yeah, we don't have the ability, but these guidelines would state that yes, we should. And the problem again also arises with the cost. We have one inhaler for use of maintenance at home. We usually need a second short-acting beta agonist, albuterol, for school. We work constantly to have that available for them wherever the child student may be. But it's difficult to achieve that when we have payers not acknowledge that it's not FDA approved for PRN use and will not provide for payment of a second inhaler. In the United States, I have patients, families being charged $150. One parent had one inhaler that they said this inhaler is prescribed. The pharmacy said it would cost me $400 to purchase. So that's another barrier to use of this. We hope that will change. I have to say I've not looked at the FDA website and see what's actively being considered, but we hope that will come soon and we have that opportunity. And it will mean that we have to really kind of rethink our recommendations, our decision-making in choosing therapy, and educating families in use of this. So through the years, we all know that there are some patients who have used their inhaled steroid or their combination inhaled steroid long-acting beta agonist as their rescue inhaler, not recognizing that we recommend continued use of the albuterol for their acute symptoms. So in reality, some patients are actually using that, and in reviewing, I'm surprised that they're doing that, and that has been actually quite acceptable for their asthma control. So thank you all for being here. Have a good rest of the day.